Thank you for joining us. We're just going to give it one more minute to let everyone come over from the waiting room. Well, good afternoon and welcome to the Ethics Grand Rounds from the Center for Bioethics and Humanities. We're really excited for our presentation today titled A Social Justice Framework for Neurodivergent Adults, Shifting to a Supported Engagement Model. Before I get things started with our presenters today, I'm just going to go over a couple housekeeping items. Please note that the viewpoints expressed during this presentation are the speaker's own and do not necessarily reflect the beliefs or practices of the Center for Bioethics or UCHealth. We encourage open dialogue and critical thinking as we explore these important topics together. I'm going to be moderating today's session. If you have any questions, you can throw those in the Q&A, but chat has been disabled for this. We'll read as many questions as we can at the end of this. CMEs and certificates of attendance are offered for this talk, and you can find out more information about how to access those through the links provided in the chat. But also when you exit out of Zoom, it's going to open a new browser for you where you can then complete a survey to claim those CMEs or certificates. And our next Ethics Grand Rounds in April will be on the 9th, and it is entitled The Fluoride Divide, Navigating Ethics at the Intersection of Public Health and Individual Rights. So with all that, I'm happy to introduce our speakers today, Nanette Elster and Dr. Kayhan Parsi. Nanette is the John B. Francis Co-Chair in Bioethics at the Center for Practical Bioethics and professor at the Neiswanger Institute for Bioethics, Loyola University, Chicago Stritch School of Medicine, where she teaches courses in pediatric ethics, oral health ethics, genetics and ethics, professionalism, and disability ethics. She is the legal consultant to the Committee on Bioethics of the American Academy of Pediatrics. She was the manager of ethics outreach for the American Dental Association. She received her BA from the University of Illinois at Urbana-Champaign and her JD from Loyola University Chicago School of Law and her MPH from the Boston University School of Public Health. We also have Dr. Parsi, who is the John B. Francis Co-Chair in Bioethics at the Center for Practical Bioethics and Professor and Graduate Program Director at the Neiswanger Institute for Bioethics, Loyola University Chicago Stritch School of Medicine. He is an active educator in the Stritch School of Medicine and also serves on the Loyola University Health System Ethics Committee and is an ethics consultant for LUHS. He received his BA from Rice University, JD from University of Houston Law Center, and PhD in Medical Humanities from the University of Texas Medical Branch at Galveston. We're so excited to have you here today, and we're going to give you the floor to present. Thank you.
Thank you so much, Jana and Chelsea, for inviting Nanette and myself. We're delighted to be here to talk about this topic that's so near and dear to us. And so we hope you all find this of interest and helpful in your own education. These are our disclosures, so really have no conflicts to disclose with you all. These are our opinions that we're sharing with you, and they don't reflect the institutions that we may be affiliated with. And then lastly, we are neurotypical parents of neurodivergent adult children. Here's the overview of our presentation today, just to give you an idea of what we're going to be doing today. We're going to talk about, so we're first going to talk about this social justice framework. Why is this important for us? Why is it important for bioethicists to talk about social justice? And then we'll spend a little bit of time talking about this issue of neurodivergent or neurodiverse adults who have been historically understudied, especially autistic adults, and why that is. And then talk about this distinction between entitlement and eligibility, something that we've talked and written a great deal about. We think it's a very important distinction that we just want to draw out in this presentation. Then move to these different forms of decision making, supported decision making, and how that applies to not just to healthcare, but to other realms of life. And then focus more on this concept that we developed called supported engagement. What does it mean? How does it apply here? And then next steps. Now, I'm sure most, if not all of you, are familiar with this quote that was stated by the current Secretary of the Department of Health and Human Services, RFK Jr. I won't read the whole thing, but what he says at the beginning is autism destroys families, and more importantly, it destroys our greatest resource, which is our children. And this sentiment, unfortunately, seems to be pervasive in this administration, and really reflects a ableism that's pervasive throughout society. And that's something that we're trying to really address in this work, is this individual ableism, but also the systemic ableism that really affects a variety of people, particularly people who are neurodivergent and autistic. And as you can see by this quote by this 70-year-old, um, it's he says autism doesn't destroy families, it's the ableism that does. And so that's really the at heart, and that's what's at issue here, is the ableism that's expressed in sentiments like this. Now, why is social justice important for us? This was a study that was published about a year ago in A-Job Empirical Bioethics, and they surveyed a number of bioethicists, 355, about their attitudes and beliefs and values regarding social justice. And according to that survey, 75% believe that it should be a key aim of bioethics scholarship. So something that should be very important and written about by bioethicists. And also this idea that it should be communicated to others. And what I've seen over the last several years, 20 years, is this shift towards more attention to social justice when it comes to bioethics scholarship and the kinds of things that we're engaged in. This was a graph from that study, and the question was, which do you consider to be the most important actions related to social justice that should be required or strongly encouraged? And you'll see the top three are basically writing or engaging with a variety of different audiences, whether they're academic, non-academic, community, and we really resonate with that. We really think that these kinds of topics for bioethicists like ourselves, we really should be engaging with a variety of audiences, not just academic audiences like this, but with community members, schools, libraries, community organizations. We think it's a really important topic that should be engaged with on a variety of different settings. Now, I mentioned earlier that historically the focus has been on autistic children. That's very much the case. If you've been following the literature for any length of time, if you look at policies, if you look at the discourse, the focus has always been on children, or I would say primarily on children. And this was a piece published a few years ago. Um, and it states at the end, autistic children are still the focus of the majority of research articles, research accounting for less than 1% of all publications over the past decade. So that's really very telling, that the vast majority of work is done on children. And it's an interesting phenomenon, because typically we hope children grow into adults. And so we spend most of our lives as adults, and so we hope to shift attention, not to discount or dismiss autistic children or neurodivergent children, but to realize, hey, there's a lot of people who are dealing with a lot of challenges throughout their adulthood.
So, just to contextualize this a bit more, U.gov does these surveys around the country, and this is a fairly recent one from about 2 years ago that said neurodiversity in the US, about 19% of Americans identify as neurodivergent. That's a pretty big number, and a number we probably need to pay some attention to. Breaking down whether this is a medical diagnosis or self-diagnosis is unclear. Nonetheless, this is a good portion of the population. Next slide, please. So, as Kayhan mentioned, we have a lot of information about kids, and it comes out just about every year from the CDC. The most recent, which I don't know if we'll see it coming forward, but the most recent data shows that 1 in 31 children are diagnosed as autistic. Those are the rates of autism in the US currently. Adults haven't been studied nearly as much. There's only been one really large-scale study of which I am aware, and that was done 4 or 5 years ago. And it reflects that at that time, 1 in 45 adults were diagnosed as autistic. And again, this is a medical diagnosis, not a self-diagnosis. But those numbers don't match. We know that autism doesn't go away. It's not something that disappears once one reaches the age of 18. So those 1 in 31 children are going to grow up to be adults, we hope, most of them. And if that's the case, we need to do a better job, and we probably need to think about that number when it comes to adults. Next slide, please. So I mentioned before this concept of self-identification. So with adults, particularly among women, LGBT community who may have experienced previous negative encounters in the healthcare system, they won't go for a formal diagnosis from a physician, but they might, through various tools available online, some good, some not so good, they might self-diagnose. And this can be helpful in building community. It could be harmful in limiting access to appropriate care and treatment. But it is important to understand that this is also something that we're seeing and may be contributing to some of those increases we're seeing of recognition of neurodivergence in adulthood. Next slide, please. So this is a pretty recent study in JAMA Network Open talking about diagnosis and the fact that we are seeing more adults. And the last sentence here, I think, is really important for our purposes and for this idea of supported engagement that we'll share with you shortly. It says these findings forecast a substantial number of autistic people aging into adult care. So our pediatric system is pretty well equipped, but still has its gap. Our adult system isn't adapted at all to autistic and other neurodivergent patients. So that's something that moving forward we need to think about. And it's not just our healthcare, it's many of our systems, our employment systems, our educational systems, even social structures, political structures aren't thoroughly designed for autistic adults. Next slide, please. So as I mentioned, some folks are getting diagnosed later and later. And here are just a few reasons or explanations why that might be happening. Because our focus has long been on children, the diagnostic tools for adults are a very recent phenomenon. In fact, many adults who seek diagnosis will go through the same battery of tests that a young child will, including, things like putting together puzzles and structured questions about how easily do you make friends? What troubles have you had in school? What's your relationship like with your parents and your siblings? And parents might be asked, at what age did you first speak or did you first walk? These are not particularly relevant to adults. And so we are seeing these tools gradually coming into play where we can specifically diagnose an adult. Sometimes these adults are thought of as perhaps the lost generation who sort of missed out on this ability to get diagnosed through schools or through their pediatric office. There's also a gender bias. So a lot of times girls and women will be diagnosed later because they might have very uncharacteristic presentations of what we've previously considered as exhibiting autistic behaviors. They tend to be much more compliant in school, for example. They might have more, their interests might be more socially accepted interests. You can see where the ableism's kind of creeping in here. This gender bias couples often with diagnostic overshadowing, and that's when clinicians stop at one presentation to not look for other diagnoses. In women, that diagnosis often happens to be other mental health conditions, particularly things like borderline personality disorder. So a woman might get diagnosed with borderline personality disorder. All of the treatment will revolve around that to the exclusion of examining the possibility that there might be underlying autism or ADHD, which actually might explain the presentation of symptomology that looks a lot like borderline personality disorder. So these things converge to lead us to some late diagnoses. Next slide, please. So why does this matter? Why are we so concerned about what this means for adults, particularly through a social justice lens? Next slide, please. Well, a lot of it has to do with this concept of entitlement versus eligibility. There are a lot of services that our state and federal governments have provided in the past. Social supports, educational supports, healthcare supports. Under the age of 21, sometimes it's a little lower. It might be up to the age of 23. In some states, there is variability. But in general, 21, there's an entitlement. to a whole range of services. And by entitlement, that means the state is obligated. The burden is on the state to provide them. And this is pretty much coordinated. It can be coordinated through schools or through the healthcare system. However, and this is often described in the literature on parents of adult autistic children who are transitioning from adolescence to adulthood, it's like falling off the cliff because all of a sudden you've gone from eligibility, from entitlement to eligibility. Eligibility is what happens after the age of 21, but who's eligible for what is variable. So those services that might have been provided to someone as a child, you might or might not be eligible once you reach adulthood, but you have to know what that process is like, how to apply, when to apply, what are the barriers to application? Sometimes income might be a barrier. Sometimes education might be a barrier. Sometimes living at home might be a barrier. The burden, however, to figure all of this out is on the individual or their family members or perhaps a guardian. And so it becomes a much more disparate and confusing system to navigate. Next slide, please. So this is just a different way of expressing this. A child, for example, is entitled to services that it might involve housing or in-home care, a range of healthcare services, as well as a range of social and educational services. Here, parents and or guardians are decision makers. They kind of call the shots. They're the ones with whom all of these services are being coordinated, and there is a coordination of care. There's generally case managers involved through, like I said, it's schools or pediatric health centers. So it's much more coordinated than it is diffuse. For adults, however, they're eligible for services, and that eligibility can vary from state to state, from locality to locality. Housing might be eligible, might not. Healthcare, again, maybe it's Medicare, maybe it's Medicaid, maybe it's none of the above. Maybe they can stay on their parents' insurance even beyond age 26. Employment, what is accessible or available to one in the employment context? They can make their own decisions, typically, unless it's determined legally otherwise, either through an advance directive, which we'll talk about, or a guardianship proceeding. And what happens here is all of a sudden we see an enormous exaggeration of disparities, not just in healthcare, but in housing, in employment, and all of those things. All right, so back to Kayhan.
So we've been talking about uh, a variety of issues, and here I want to just shift more to the challenge of decision making and focus on healthcare, but then talk about a number of other settings where decisions have to be made. Now, this is just an infographic that gives you a snapshot of a variety of challenges facing autistic adults, whether it comes to healthcare or employment, education, relationships. So, I mean, I know that this infographic, really focuses on the challenges, and they are serious, and we want to argue that a lot of these are systemic in nature, and so we want to try to address that with our approach. We have a lot of different tools to help people make decisions, particularly in healthcare. So there's some that have been around for a long time. Of course, there's guardianship, which is the most extreme form of decision-making authority where someone else is granted legal authority, typically by a court of law, to make decisions for someone else. And it's very comprehensive, of course. It's not just healthcare, but here we're going to focus just a bit on healthcare. It's a process where someone is state appointed, and so that person's basically their decision-making authority is removed by the state. Very extreme, and something that we usually view as a last resort. Now, of course, the individual, him or herself, can make decisions for themselves if they have capacity. Um, but then the individual can also help make decisions for them. So someone can appoint a double power of attorney for healthcare, and that agent can start making decisions immediately. It doesn't have to be triggered by the loss of capacity. And then there's also supported decision making, and that's the new trend we're going to focus on here, something that's been going on now for some time. And you see that there's this kind of spectrum between making and supported decision making, and we're going to focus on supported decision making. So this may be familiar to many of you by now, but this is a form of decision making that it maintains the autonomy of the person making decisions through the assistance of another person. Now, it may be often seen through the lens of, say, cognitive disability or cognitive impairment. So someone who has disability related to cognition, it could be an intellectual disability, it could be someone with dementia, a variety of factors at play. Um, and as I mentioned, there are other ways to help that person make decisions. There's guardianship, which again we view as a last resort. But this trend towards supported decision making really is seen as a way to not take over the decision making authority of that person, but really to help guide them and support them. And we think that there's a role for those of bioethics to help educate people about this decision making tool. How can it be used effectively? How can it be used to help realize the person's autonomy? And this isn't just focused on the US. Um, Although there's a number of states now that have adopted formal legislative movements. So as you can see here, the UN Convention on the Rights of Persons with Disabilities has made it clear that it's important that this kind of trend continue. It says that the UN, this convention was signed 20 years ago, and Article 12 states that state parties shall recognize that persons with disabilities enjoy legal capacity on an equal basis with others in all aspects of life. So again, it's an attempt to address that systemic ableism that I mentioned earlier. And it really is, so specifically here in healthcare, but in a variety of different settings, as I'll mention later. So to help people understand their choices, what are the issues that they're facing, it can come from a friend, it can come, and to help that person ask the right questions with regards to whatever decision they're facing and to receive explanations. Ultimately, it's to center that person in the decision-making process, um, and to communicate those choices to whomever, particularly, say, a healthcare professional. So with this trend of supported decision making, which now about roughly half the states have adopted, the first two states were Texas and Delaware. Now it's about half the states have formal legislation on the books with regards to supported decision making. So there is this commitment to this legal trend among a variety of states now. We're trying to argue for a broader commitment beyond just facilitating decision making. We think that's important, and we want to help people realize their autonomy. But ultimately, we think about autonomy in a relational manner, relational autonomy. And so we want to expand that to something we call supported engagement, which will ultimately lead, we hope, to a greater social justice setting, situation, and greater human flourishing.
So I want to take a few minutes now just to talk about what supported engagement is, why we need it, and how it might work. So this is conceptual at this point, and we'd certainly welcome feedback and your thoughts about this concept. Next slide, please. So it is a new conceptual framework, as Kayhan mentioned, that acknowledges relational autonomy. It builds out this concept of supported decision making where the individual is centered. But it moves beyond mere decision making because we can all make decisions. But how do we effectuate those? And often to effectuate those, we need things around us to support it. It can't just be, I decide this, so we're going to do it. Like, I want to live here, so we'll make it happen. But how do we really operationalize that? How do we make it so someone who might be neurodivergent, who may have waxing and waning capacity, can actually be able to do what it is that they're deciding to do? Next slide, please. So what it does is it highlights engagement with neurodivergent individuals and their support needs, as well as the support needs of their caregivers or supporters. So we kind of have to look at this much more holistically. And we need to ask people what they need as opposed to telling them what they need. And it definitely extends beyond individual supporters to things like organizational supporters or institutional supporters, governmental supporters. And it extends beyond those with impaired decision-making capacity. So it really, as we should have mentioned very much at the outset, just because one might be autistic does not mean that they experience an intellectual disability, but they still might have support needs. And that's a really important factor to keep in mind here, that those support needs may seem a little less obvious, but they exist nonetheless. And so it's really important to involve individuals within this dialogue and to not just focus on impairments or something that is deficit based. Next slide, please. So as I mentioned, it encompasses institutions and organizations, both public and private. So it's important to get back to this idea of our communities, and communities can be a great source of support. And it recognizes the need for a participatory approach to policy development. We talk about this a lot in research, those of us who do bioethics. We talk about participatory research, but we really need to think about this in the policy arena and how important that might be so that we can get to this point of human flourishing and a greater balance of social justice within this community.
So there's a variety of ways that this can be realized, and often we focus on the individual level. So within healthcare, we typically focus on the clinician patient, and so how can this kind of engagement help realize not just supported decision making, but supported engagement. There's a variety of different resources that are available, but often it's really hard to coordinate. And this is something that we've been studying for many years when autistic adults, for instance, transition into young adulthood. A lot of those services, a lot of those resources go away. So it's called aging out of the system. More dramatically, it's called falling off the cliff. And so how can we better marshal those resources to help support healthcare decision making in an effective manner? How can we help support relationships in general for neurodivergent adults? And then certain life skills that are really important to what we're hopefully trying to aspire to, which is human flourishing. And when we talk about healthcare, of course, we're not just talking about medical care, which is obviously important, big component of everyone's life. So we're not just talking about medication or surgeries, but we're also looking at oral health care. Oral health care is often neglected, and that's done a great deal of study and work in this area of oral health care and oral health justice. But oral health care is often neglected, and so how to again marshal those resources for autistic and neurodivergent adults to make sure that oral healthcare needs are met, especially in light of the fact that medical care and oral health care is often segregated, and the same kind of insurance models just don't exist for oral health care as they do for medical care. Mental health care also a huge part of this. Again, often neglected, under-resourced, underutilized, and so again, how to get this kind of care to folks in this community. Sadly, a lot of neurodivergent or autistic adults have a lot of other comorbidities, and so a lot of those get neglected in overall health care. And then there's self-care, how to implement self-care through education and through other kinds of interventions to make sure that people are engaged in some level of self-care as well. So I've mentioned a few times during this presentation that, we're not just talking about healthcare, we're talking about life skills, we're talking about different kinds of resources. And so, beyond just being able to make healthcare decisions, there's financial literacy. So, typically if someone has some kind of um, capacity issue with regards to finances, sometimes a durable power of attorney for finances or property is executed with supported decision making. That can also help with trying to support people in their financial decision making, household management. Again, another big part of adulthood. And, just as a quick example, Nanette and I, we direct a course on disability health for our medical students here at Loyola. And we engage with a number of members from the community who come and talk to our medical students, who talk about their lives, not just their healthcare issues, but how they live. And they talk about this new home that was built by L'Arche, which is an international organization devoted to folks with disabilities. And so they talked about, some of the challenges and opportunities in managing a household and having the support needed to do that effectively. And then lastly, interpersonal communication. We're all addicted to our cell phones, and so how to impart those kinds of skills so that folks can use social media in an effective way, and avoid certain kinds of challenges or problems. Relationships are another part of this whole universe, and parenting relationships, very critical. What we've seen in the last, say, 20, 25 years, especially in the autism community, is kind of a shift away from the dominance of parents who have typically taken control of their children's lives when it comes to healthcare and other matters, and often are the ones steering the ship, so to speak, with regards to healthcare, to living arrangements, to housing, transportation, education, employment. And of course, in certain situations that's absolutely appropriate. Um, and in other settings, it may not be. And so making sure that folks who may need other kinds of support beyond parents, that that's realized as well. And then romantic and platonic relationships, where we see kind of in the popular culture, in TV shows, but how to support people who want these kinds of relationships and how to help them realize that kind of relationship in their own lives. So those are all the individual level. And in some of the work that Nanette and I have written about with regards to these topics, we've talked about different levels of engagement when we talk about support engagement. So we talk at the micro level, the meso level, and so the macro level. And so for the broader community, how can the community help support individuals, again, more fully realize their spirituality? Another topic that's often neglected in the literature, very little written about spirituality with regards to this community, but how can that be further supported? And uh, the two others that are listed here are often the ones that are given the most attention, especially housing. There's been a fair amount written just in the popular press about housing and autistic adults and the needs that are present there. And as we all know, we are living in a housing crisis in this country where housing prices are extraordinarily high, especially in certain markets. And so, how can we better support neurodivergent folks in getting the housing that they need? Um, the trend over the last 50 years has been group housing away from institutionalization, which was the dominant model up until the 70s. And against that model has been the group home. Do we need to rethink how housing is designed? for folks in this community? Should it be more like a campus environment? Should there be other kinds of supports? So this is something that I think really we really need a lot more attention as far as scholarship, as far as community activism, and as far as policy work. And then, of course, employment. And that earlier infographic that I shared with you all, it mentioned the fact that many, if not most, autistic people are either unemployed or underemployed. And so how to better support the needs of this community, again, to get them engaged. There's some great models out there in the book that Nanette and I co-edited a few years ago, where we looked at this transition from adolescence to adulthood. One of the contributors was one of the co-founders of an organization called Aspiritech up in Highland Park, Illinois, just north of Chicago. And their model was to employ only people in their organization, and they really had an amazing track record of success, realizing that they had to provide certain kind of support, certain kind of accommodations, but that with the right mindset, with the right sense of purpose, it could be really a very successful kind of model. And then lastly, this idea of civic engagement, and here at Loyola, but we think it's really important that members of this community are involved on a variety of levels. There's advocacy, not just self-advocacy, but community advocacy, that they're involved in policymaking. So these policies affect so many people's lives, particularly people in this community. And as I mentioned earlier, that sentiment by RFK Jr. is probably not unique to him. And so we need to have folks in the community to help create more sensible and more just policies. And then getting involved in the political process. And that means not just voting, but running for office, or helping someone's campaign, getting organized. So, when we see real change, it has to happen through that level of organization.
So, how do we do all this? It's a lot. One thing we can do is educate communities about neurodiversity, what it means, what it doesn't mean, how it is not a monolith, and how it has many, many nuances. Um, Developing supportive services for neurodivergent individuals and their support persons. So the support person doesn't just step in and fill those shoes. We often see this, for example, in healthcare with a surrogate decision maker or a power of attorney for healthcare. There's no training on what to do. So you're just kind of thrown in there, say, okay, you get to make this decision now. And oh, by the way, you're going to use a standard called substituted judgment, um, without much explanation of what that means. So here, support persons also need some understanding. What am I doing? How do I support? Yes, I know this person very well. So how can I use that to help them make decisions about where to live, who to live with, what job to take, all of those things that a supporter might be involved with. Another thing is to encourage employers, healthcare providers, et cetera, to focus on strengths and contributions rather than on deficits. The course that Kayhan mentioned, the disability health course that we are faculty advisors on, this is a lot of what they're trying to do is work with healthcare providers to have them engage with community members to really understand what their needs are, what their wants are, and how best to address all of that, including perhaps exercising humility and just asking a simple question like, how can I best help you? And then to identify meaningful engagement of neurodivergent individuals based on individual rather than stereotypes. So we want to focus on what that individual needs, not stereotypes. This focus on how we all think of neurodiversity and what it looks like may not be accurate. There are a lot of nuances to it. What we used to see in mainstream media was very much this savantism, which is fewer than 10% of the autistic community, like Raymond from Rain Man, the Dustin Hoffman character, who you dump a bunch of toothpicks on the floor and he can count all of them. And for the longest time, that was people's perception of what an autistic adult looked like. Or now we saw in The Good Doctor, he has a unique skill to be able to visualize every part of the body and know exactly what's wrong in it because of his unique skills at visualization. Um, these are not accurate representations and depictions, so it's important to start focusing more on individual things. And we're starting to see that through different portrayals, through, for example, The Pit, Dr. Mel. Um, and we're also seeing it in some reality TV programming that's gained a little more sensitivity toward looking at these individualistic nuances. Next slide, please. So, engaging neurodivergent individuals in the political process, as Kayhan mentioned, is really going to be critical to this idea of supported engagement and its development. So, educating about the political process, community consultations. Again, we see this often in research where we engage with a particular community, we consult with them about what their needs are, what their wants are, and how they think we can best achieve that. Voting is certainly critical. Another reason to maybe think more about things like supported decision makers as opposed to guardians, where in guardianship that right to vote might be lost. In running for office, if one has the capacity, one doesn't have any intellectual disability that might impede them from participating in elected office, this could be a really important mechanism. And then consider the individual support needs of the individual with and without intellectual disability. I think we really try to stress this because those without intellectual disability are often dismissed or judged particularly harshly because, like, you have a job. What kind of support would you possibly need? You work full time, you live on your own. That doesn't mean that all of that comes without its challenges. We know, for example, that many people who are in those roles without intellectual disability might mask. For example, they might camouflage their autistic traits, for example. Those who mask, according to some studies, are at a 9 times higher risk of suicide. So this is an important thing for us to think about and to consider what that support might look like. And then we need to look at the individual support needs of the support persons. This can be something someone needs some education about or needs to know what services might be available, what decisions are important. And then also the needs of those who engage with or treat neurodivergent individuals. So when you talk to our medical students put this course together because they felt ill-equipped to treat patients with a range of disabilities. And so the students spearheaded this course as a way to improve their comfort, their exposure, their abilities to communicate. Next slide, please. Our end goal is to move away from a deficit focus to a strength enhancing approach, hence the human flourishing, and to identify individual, systemic, and structural barriers that might be impediments, and then to recommend and develop community-based participatory approach for civic and community engagement to help overcome some of those barriers. Next slide, please. So I want to end with this quote from Stat News. It was a couple years old now, but I think it really hits home to this idea that we're talking about adults and how adults have needs that we haven't quite met yet. And I'll just read it here briefly. In the face of these desperate needs, it's time for our community to stand strong and advocate for the services needed for ourselves and families. Wealth, race, or cognitive educational privilege should not be the deciding factor, predicting who survives and prospers in living an autistic life. There are a lot of us, and what's truly increasing is the cost of ignoring our needs. It's high for us as individuals and for families, and even higher for society. So I think that really summarizes the importance of the need for supported engagement and for this greater involvement and a recognition that this really is a social justice concern. So with that, we'd like to open it up for questions. These are ways to contact us. We're more than happy to, if we can't get to your question now, please don't hesitate to reach out to either one or both of us.
Nanette and Kayhan, thank you so much. This has just been a really informative talk, and I think I speak on everyone in this Zoom call when I say we're really grateful for your advocacy in this area. If you gave so many practical recommendations of things we can do and potential changes we can make to kind of shift our mindsets and also, the frameworks in which our current world operates. But, if there was one thing that you could ask all of us to do tomorrow or change in our own healthcare practice, what would that be?
I think for me, it would be to be self-aware of our own ableism. For a lot of us, it might be internalized or externalized, but and to have that humility, as I mentioned. If we're unfamiliar, best not to presume or assume what someone's experience is. So take that time to engage in maybe a little deeper conversation. Narrative is really, really important here.
Yeah. And I would add to that idea of being aware of ableism is to just learn more about the community. I mean, learn more about this community. It's a very broad community. It's very heterogeneous. So, we really try to not paint with a broad brush. And as Nanette said, it's not a monolith. But there's so much information now compared to 10, 15, 20 years ago. So I would just encourage folks to just get educated about this community as much as they could.
Great, thank you. We have a chat in or a question in our Q&A about a kind of autonomy related with these individuals. Should not the issue of social justice for neurodivergent adults be fundamentally about autonomy, even given supported engagement? One may be autonomous, but just how independent or functional are they? The problem with concepts like independent living and so forth is that independence is often fetishized into an unattainable ideal. It would be more correct and humane to promote autonomous living.
Yeah, I think that we just had this conversation yesterday. How many CEOs of Fortune 500 companies are independent? They don't pick up their dry cleaning. They probably don't even do their own laundry or cook their own meals. So I think that that's a really important point, that it's about the individual deciding what's important to them. And I think what we've learned in this community, so again, I'm talking about those without an intellectual disability, but they may experience some things that may not reflect independence. So meal preparation, for example, may be a tremendous stumbling block because of a whole range of executive function issues, from the planning, the shopping, the cooking, the cleaning up. And so, a solution is prepared meals. Does that mean you're not independent? You can't take care of yourself because you eat out every night? No. So I think this also ties back to the idea of, let's get rid of the ableism and the judgment that comes in there. If this person recognizes that this is the support they need to maximize their skills and reduce the deficits, then that should be acceptable and reflects autonomy in a way that it maybe doesn't match what our typical idea of an independent adult looks like.
I wanted to pick up on that word that you use, fetishize independence. I think that's what you said. That question was asking. I think that's right, that we do fetishize independence to a great deal. And the reality is that if we have the support, so if we're fortunate enough to have a support group or network of people, family members, friends, trusted professionals that we can lean on to help make decisions, that's when supported decision making really can be very effective, right? Because then you can pinpoint someone to help you make your decisions. Um, and so our idea of relational autonomy is that, look, we don't make decisions by ourselves. We're interdependent beings as people, and so we need the help and support of others. And so I think that's important. And then there's this idea, which we didn't mention in our presentation, but I'll just mention briefly, is this idea of dignity of risk, which has been mentioned a lot in the disability rights and disability ethics literature. And this idea that disabled folks have a right to take reasonable risks with their own lives, just like everyone else. And so we want to balance that kind of paternalism towards disabled people. We don't want to be paternalistic. We want to say, look, you can make your own decisions. Um, but also provide support. And I think that's really the balancing act.
And I'm really interested in, yeah, your supported engagement model. I wonder, do you guys see that analogously, well carried out in any other settings or with different groups, or yeah, or do you even see it being applied in other places beyond neurodivergent?
I think ultimately we would hope to see a similar approach taken across the idea of disability, but again, because there's such variability and you know, how one might identify as something disabling, is something an identity, is there a crossover? I think for us, we didn't want to go too broadly without starting somewhere that seemed manageable, focus where we had a personal connection that's allowed us to see how very different this community is, even within our own family structure. And so hence we chose this as a starting point. But could this model of supported engagement apply more broadly? Absolutely. And I think we would hope to see that happen because it really does take into account the various models that are currently applied when someone might have a disability or a deficit. That we might be able to work together better to reduce structural barriers, systemic barriers, and basically take down ableism a notch or two.
The question about do we see this model played out in other settings? I mean, that's a great question. One place that I've seen it, which I think, it just came to my mind, but when you look at young people, and, and they go off to college, that's a place where they're given some level of autonomy and independence, but they have support, right? They have support of their parents, they have support of professors, they have support of other members of the campus community. And it's an interesting time in one's life because it's seen as kind of this transition into adulthood. Like, okay, you've lived with your parents for 18 years. Now you're going to be in this kind of semi-autonomous, semi-independent space for 4 years. You can kind of take some risks. You can kind of do some things on your own. Ultimately, your parents are, kind of paying the bills. And then you transition away from that setting. And it's interesting going back to my earlier comment about, say, for instance, housing for autistic and neurodivergent adults. The campus model has been looked at as maybe a feasible, tenable, model for folks in the community. Maybe as an alternative to say group homes or group housing, which has been the dominant model. And so if you look at that campus model, say, oh yeah, like who wouldn't want to live like, I mean, like you're hanging out with your friends and you've got supports for food and everything, and you've got recreation, you've got intellectual activity. So anyway, so that's, I don't know if that's an example of supported engagement, but it's this kind of interesting model where, you know, young people can have some measure of independence, but still have some level of support as well.
I really like that comparison. And you guys have done that throughout your whole presentation, that I think for those of us who may not have that personal experience, we can then say, oh my gosh, yeah, I know exactly what you're talking about in those scenarios. I also thought it was really interesting how you comment on this idea of, lacking a formal diagnosis. And we have a comment or a question from a viewer who said, as someone who has looked into being tested for autism for myself, it's shocking how difficult it is to find an adult provider, for an adult to find a provider. There
Mhm.
are thankfully a lot of options for children, but as you noted, not for adults. How can we push this change and awareness within the medical profession?
I think if you have a trusted healthcare provider, even if it's your internist, being able to talk that through, or if it's a mental health provider, I do think awareness is growing. And as I said, we're starting to see more diagnostic tools being adapted for adult diagnosis. What I've seen is this is primarily a grassroots operation here, is really trying to push this forward. And so we are seeing self-diagnoses, and then self-diagnosis might result in then going to a clinician and saying, okay, here's what I've discovered. These are the reasons why. Now let's see how we can work together to formalize this so I might be able to get the care and assistance that I do need. Now, on the other side of that, we see a lot of individuals who've been unable to access that formal diagnosis and have been harmed or traumatized by their encounters in healthcare because they've either been misdiagnosed, they've been dismissed, they haven't been treated in what we'd say fairly or justly. And so they turn to self-diagnosis because there really is no other place to turn. So I'm hoping that as awareness increases, we will begin to see more and more. We're also seeing more providers who themselves are open about their neurodiversity. And so this issue of concordant care, we talk about race concordant care, gender concordant care. We haven't really talked a lot about neurodiverse concordant care. And I think that that is something that we're starting to see a little bit more about. To go back to my example in the pit, there's a really great episode in the pit where we do see that, where the neurodivergent physician comes in and saves the day with a neurodivergent patient by talking in the right way, turning down the lights, really getting at what matters to him and explaining things to him in a way that he understands.
Thank you. We also have a couple different questions in our chat, just practically speaking about, what does this look like in with existing policies, or what can we do to make supported decision making happen for these patients in clinical settings, in especially considering like ableist structures that exist within our healthcare systems.
That's something we're really trying to address now. Nanette and I are involved with a couple of colleagues through our work with the Center for Practical Bioethics, where we're really trying to better understand the state laws. So Nanette's been gathering all these laws. We're going to analyze them. And then out of that, we really want to develop really robust and effective educational opportunities for clinicians, for clinical ethicists on how to better implement and integrate supported decision making in clinical care. Nanette has a great anecdote that she likes to share about like the lack of knowledge with regard to supported decision making, that she was involved in some ethics committee meeting, and one of her colleagues who does a lot of work in adolescent medicine had never even heard of this, and so that just suggests that, oh, there's a lot of work to be done for us here in bioethics, and particularly in clinical ethics, to better educate folks. So I think there's opportunities for better education, certainly, and going beyond, again, just beyond the academy, beyond healthcare, but with the community. And we're big supporters of taking this work out into the community and engaging people in their lives in these different settings, as I mentioned, schools, libraries, civic organizations, and so forth, so that they understand, like, hey, we're all going to need some support because of illness, because of disease. Something's going to go on. And so it's better for us to have these tools, or at least know about the tools. And if we need to take advantage of this, so at least we understand how it works, how it can be implemented. And so I think, yeah, there's some really great opportunities for education here.
Yeah, and I think sometimes it's just about arming people with the right tools for their own self-advocacy. So we really want to address this on as many different fronts as we can.
Awesome. Well, thank you both for this wonderful conversation and all the advocacy you've done and inspired us to do. And thank you for everyone for attending today. We hope to see you next month on April 9th for the fluoride divide. Thank you.
Thanks.
Thanks again.